So thank you, Daniel. Good afternoon to everyone. And thanks the organizers of the Great World Congress, this joint session with the World Heart Federation. And in my presentation, I will address the current situation of how optimize the secondary prevention according to the latest evidence. My disclosures related with the presentation. And first, on this slide, you can see the impact of ischemic heart disease in India population worldwide, and particularly in China, and huge discrepancies on the incidence of and prevalence of ischemic heart disease in Central Asia, that is Central China, lower that is the highest ischemic heart disease prevalence worldwide, then East Asia, that is the east coast of China, and the lowest, and it is really impressive, this figure, the lowest prevalence of ischemic heart disease is in high-income Asia-Pacific countries. So a huge difference in prevalence of ischemic heart disease can be seen in China, highest in the central China, the lowest in the Asia-Pacific, and particularly high-income Asia-Pacific regions. And the main determinants of ischemic heart disease also can be seen on this slide is air pollution. Air pollution is a major problem worldwide, and particularly in some areas in China. High blood pressure, and also high cholesterol, and unhealthy diet. So on this slide you see the huge differences in the prevalence of ischemic heart disease and the main determinants of ischemic heart disease in Jewish population. The World Heart Federation, the goal of the World Heart Federation is provide healthy cardiovascular lifestyle around the globe, and we develop different tools and the roadmaps and tools for implementation of the guideline recommendation, how we implement the evidence, and in this case, the guidelines recommendation, and thereafter, Daniel Piñeiro will address the roadmaps, the secondary prevention roadmaps, and the major goals for implemented the better evidence in secondary prevention. This is the secondary prevention roadmap, the recent updated publication of the secondary prevention, how to implement the best practices for optimize the secondary prevention. And there are several issues. As I said, Daniel will address this issue. Is needed to implement digital health technologies for helping to optimize the secondary prevention, use fixed dose combination, also devising the influence and the COVID vaccines, and also implement innovation, not only in drug treatment, but also innovation in device therapy. In my presentation, I will address this issue, how translate to the individual patients the latest evidence, or how to translate to the individual patients the guideline recommendation, that is implementation science. And this is the really important issue in the daily practice, how to implement the science to your patients, how optimize our your patients in the daily practice. And for this, you have to organize a patient journey. On this slide, you see a proposal for organized a patient journey. After an acute coronary syndrome, you have to optimize the early diagnostic, early management, probably early revascularization, and optimize during the hospital state the risk stratification, and also optimize the treatment. And you have to then to organize the follow-up with the GPs, with nurses, with cardiologists, and you have to clearly define how to follow such kind of patients according to the timeline, decisions, and when and how to review and assess the clinical status of the patient. But I think it's needed to plan or to assess two issues. One, is needed to optimize the treatment at hospital discharge, and what is treatment optimization at hospital discharge. And then you have to include in this patient journey, in this patient pathway, quality indicators and that can give you the opportunity for looking for the opportunities for improvement during the patient journey. So at local level, at your local level health organization, how do you organize the patient journey after, in this case, an acute coronary syndrome? And this is a proposal of our health area. And what about the latest evidence regarding how optimize the management of patients with ischemic heart disease? On this slide that was recently published in the New England Journal of Medicine is after an acute coronary syndrome or in patients after revascularization, in this case with PCI, is not needed to assess ischemic risk. It's not needed to perform routine stress tests because the patient randomized to a stress test compared with usual care was exactly the same outcome. So it's not needed to routinely perform an stress test after an acute event or after a revascularization procedure. This is really important because this is not need for routine ischemic tests in your patients. And you have to consider how optimize how this comprehensive optimization after this acute event. You have to induce lifestyle changes in your patient. You have to organize the best treatment strategy, medical treatment strategy, and also you have to consider beyond the acute phase, the revascularization during the acute episode, primary PCI or revascularization in non-STEMI, the role of revascularization in the follow-up of your patients. And first, the better, and the guideline recommendation is, if it is possible, you have to organize a cardiac rehabilitation program at local level in your health area, include the patients after an acute event or after a revascularization procedure in a cardiac rehabilitation. That cardiac rehabilitation is a comprehensive approach that try to explain the disease to the patients and the families, and also induce healthy lifestyle changes, define goals in the risk factors, and this slide summarize the goals on the different risk factors, the LDL goals, the lower than 55 milligrams per deciliter in all the patients in secondary prevention, blood pressure goal, optimize the blood pressure control, systolic lower than 130 and diastolic lower than 80 millimeters of mercury, the role of DAPT, double antiplatelet therapy, and then one continued with single, with aspirin or clopidogrel, and in diabetic patients optimize the glucometabolic control and using drugs with proven cardiorenal benefit. So this slide summarizes this approach of regarding lifestyle changes, healthy lifestyle changes, and risk factors control. And at the end, you have to consider all these components in your individual patient. You have to include the patient in a cardiac rehabilitation and consider different treatment strategies with a proven benefit on the outcome of the patient. And as can be seen in this slide, the goal is implement as many as possible and as quickly as possible this concept of optimization therapy. But what about the latest evidence regarding this classical approach in JUA patients. What about lifestyle? And this publication was very recently published in JACC and is done in the Chinese, in normotensive adults in China. And you can see that salt restriction compared with normal salt, limiting the use of salt, was accompanied with a markedly reducing the risk of suffering hypertension in the follow-up. So it's needed, and this is an evidence, a very recent evidence in JUA population, that an intervention for reducing the salt content of the diet is very effective in reducing the risk of suffering hypertension in the future. And what about healthy diet? And again, this research was, epidemiological research was done in JUA population, and beverage with sugar and sweetener, particularly with sugar, and ultra-processed and processed meat was accompanied with a marked risk of increasing new cardiovascular episodes. And you see a marked increment in the risk of suffering ischemic heart disease, a new ischemic heart disease episode, and also the risk of stroke. So it's needed to reduce these components of the diet, reduce the sugar in the diet, and also reduce the processed food in your diet. Otherwise, can be seen an increasing risk of suffering recurrent events. So in this cardiac rehabilitation concept, healthy diet and these components of healthy diet with exercise, avoid the smoking, and other healthy interventions plays a critical role in promoting and in reducing the risk of subsequent events. What about antiplatelet therapy in chronic ischemic heart disease? After an acute event and after a revascularization procedure is needed to use double antiplatelet in patients with a lower bleeding risk. Is the guideline recommendation is using aspirin plus ticagrelor or prasugrel, and in patients with a high bleeding risk, the alternative is clopidogrel. And then, if the patient has a high risk of suffering of bleeding, you can reduce the DAPT for 3 or 6 months, and in patients with a low bleeding risk and a high ischemic risk, you can continue with double antiplatelet therapy for the longer term. But in the standard approach is 12 months of that, and then continues only in the vast majority of the patients with 100 milligrams daily of aspirin. But recently, this again was published 1 month ago, is better single antiplatelet with aspirin or with clopidogrel. On this slide you see in patients after a percutaneous coronary intervention is exactly the same regarding the prognostic and the bleeding risk of continuous with aspirin or with clopidogrel. We can choose, because on this publication the benefit and the risks are almost the same without any statistical significance. What about lipids? Lipids is not a risk factor. LDL is not a risk factor. LDL is the main cause of atherosclerosis, so you have to reduce LDL to the guideline recommendations. On this slide, the recent guideline recommendation is reduce the LDL in your patients below 55 milligrams per deciliter. This is the recommendations in all the secondary prevention guidelines. You have to early reduction and intensive reduction, and with this early and intensive reduction you can reduce the burden of atherosclerotic coronary disease, and also you can stabilize, reduce the vulnerability of the plaque. With the statins, with anti-lipid therapy, you stabilize the atherosclerotic process, and this is the approach, lifestyle, and combined therapy with statin, ezetimibe, or other new and LDL treatment with PCSK9 inhibitors, or more recently inclisiran. But lipid therapy is probably one of the major research areas in cardiovascular disease. We're awaiting for trials on the effect of drugs in reducing Lp(a). We are several ongoing trials on triglyceride or cholesterol remnants, that is lipoproteins with high levels of triglycerides. In near 2 years, in the next 2 years, we will get new evidence regarding if reducing Lp(a) with drugs, reducing lipoprotein-rich in triglycerides are also other approaches for reducing the risk, but currently LDL goal is the major goal for lipid control. What about diabetics? About 30% of ischemic heart disease patients in daily practice are diabetic patients, and you have to achieve a comprehensive approach, including hemoglobin 1IC reduction. The goal is lower than 6.5%, and using 2 classes of drugs with proven cardiorenal benefit, SGLT2 inhibitors plus GLP-1 receptor agonist, that is class 1 recommendation, and is class 1 recommendation in patients with ischemic heart disease and diabetes. But recently, the chronic coronary disease European guidelines recommend the use of GLP-1 receptor agonist, that is semaglutide, in obese, overweight, and obese patients without, not only with, but also without diabetes and ischemic heart disease. The recent results of a major clinical trial demonstrate a clear benefit of using GLP-1 receptor agonists, in this case semaglutide, for improving the prognostic of patients, of coronary patients without diabetes, but overweight or obesity. That is the latest evidence regarding how optimize the use of, in this case, drugs for diabetes, but in this case it's not only for diabetes. What about beta blockers? Beta blockers for many years was a cornerstone for secondary prevention in ischemic heart disease, but recently 2 major clinical trials consider if in the modern era, in patients submitted to primary PCI and revascularized and with a normal left ventricular ejection fraction, beta blockers are associated with a better outcome. And in the ACTION trial, you see that is emerging, but was not achieved a superiority of using beta blockers compared with placebo. So some doubts about the efficacy of beta blockers in patients, in revascularized patients with normal left ventricular ejection fraction, despite some meta-analysis. This is probably the more recent meta-analysis that suggests a possible benefit in this group of patients, ischemic heart disease, with normal left ventricular ejection fraction, because we reduce ejection fraction is mandatory because it's class 1 in heart failure, but with normal left ventricular ejection fraction in this meta-analysis is suggested a cardiac benefit. So the latest evidence is not so clear for continues to use beta blockers in all the patients. What about revascularization? After the acute event. But the ischemia trial is probably the most important clinical trial in secondary prevention patients with atherosclerotic coronary artery disease, and most of them with angina, and in this trial, routine revascularization with PCI, with angioplasty, or with coronary bypass surgery was not associated with a better outcome. So it's needed to individualize how, when revascularized, you are chronic patients, particularly if the patient continues with angina despite optimize the medical treatment, could be an option, but the ischemia trial and other trials did not demonstrate a prognostic benefit after revascularization in chronic stable patients despite the presence of coronary stenosis. And other options in secondary prevention. As was mentioned in the World Heart Federation roadmap, we have to increase the use of polypills. And recently was published in the New England Journal of Medicine the results of the SECURE trial with a polypill with aspirin, with statin, atorvastatin, 40 milligrams, and ramipril early after an acute coronary syndrome. And you can see an impressive benefit of using this polypill, single pill combination with these three components compared with usual care, and we have to promote the use of these polypills in daily practice because not only the patients are more compliant with the medication, but also can be seen some synergistic effect between the drugs. And other possible approach is icosapent ethyl, that is omega-3 fatty acid, high dose of icosapent ethyl in reduced trial, and in patients after an acute event, you can see an impressive benefit of supplement with 4 grams of icosapent ethyl in patients, in this group of patients, really impressive benefit in patients under statins with an LDL between 40 and 100, and then supplement with icosapent ethyl, you see this impressive benefit with an NNT of only 11 patients. What about, in this case, with vaccines? Vaccine is a pivotal role, flu vaccine plays a pivotal role in preventing new episodes in patients with ischemic heart disease. This is one of the more recent clinical trials. And colchicine, low dose of colchicine was also recommended as a possible strategy in patients in secondary prevention patients, and it is a class 2A indication in the recent European guidelines. So you can see the comparison among different strategies of secondary prevention, and you see that cardiac rehabilitation, smoking cessation, and flu vaccines play also a major role in preventing new events. So this is my last slide. I tried to summarize the latest evidence regarding secondary prevention, how to optimize the secondary prevention. And your question, or my question to you is, how do you translate this evidence to your patients, that is implementation science? You measure quality indicators in your patients with the aim of identify opportunities for improvement, because if you optimize secondary prevention, you have much to gain in terms of quantity and quality of life of your patients. Thanks.